the new year. I think perhaps we should have we've got the live stream on. That's great. So welcome to our meeting, the first of the new year. And can I wish everybody a very happy and probably more importantly, healthy new year. As I sit here croaking, having had bronchitis all Christmas. Right, can we have any comments about the minutes of the last meeting? Has anybody got anything to say about them? Everybody happy? Excellent. Thank you. Have your approval? Do we need hands up? Yeah, approval. Well, we haven't got any hands to say that you don't, so that's fine. Declarations of interest, please. Oh, apologies. Sorry, yes, we've got apologies.
Yes, Chairman, we've got apologies from Councillor Martin on medical illness grounds. I've not received any other apologies.
I have apologies from Councillor Robert Corden, who was ill late last night. Councillor Wilmot.
Thank you very much, Chair. I'd like to put also the apologies in for Councillor David Martin. Yesterday, Councillor Martin joined 3 other members of his family in testing positive for COVID. Councillor Martin is unfortunately that this has happened, but I feel it's regrettable that his offer to join this meeting was turned down due to government legislation. I myself have got out of bed. I've suffered from bronchitis and other things over Christmas. I've had 5 PCR tests, so I am clear of COVID. The doctors have all said that. And I've had sleepless nights about coming into face-to-face meetings at this present time. That said, I've had, sleepless nights. And as a cancer survivor myself, and because of my age, I fall into the vulnerable category. All my life, I've put civic responsibility ahead of myself, and that is why I'm here today. The last person who told me that they put civic responsibility ahead of themselves was former Chairman of Ashfield District Council, Anthony Brewer, who continued to put civic responsibility ahead of his own health concerns. Okay. Anthony sadly died of COVID right at the start of the pandemic, as you probably well know. Well, can the Chairman please write to the leader of Nottinghamshire County Council to ask him to use any influence he has in the government to enable councillors to carry out their roles remotely. COVID super spreaders like council meetings like this need to end so that we're not putting councillors or officers' lives at risk. I'm sorry to have to bring this up, but it's absolutely essential at this moment, having been through what I've been through just recently.
Councillor Wilmot, I think we all feel the same. I think we all are a little scared, but life is about challenges, and we've certainly got challenges right now. I think the Prime Minister, what day is it today? Tuesday, is making some comment tomorrow, which is Wednesday. Let's wait and see what's going to happen. It is Tuesday today, isn't it? Every day goes into the same. And let's see what happens. And I agree with you. Regarding all my parish councils, I have 23 parish councils to attend, and I shall be writing to them to say that I'm not attending, going into small rooms, and if they require me, they can write to me. And I think there are certain ways that we can take precautions ourselves, and that will be one I take. I've actually been on steroids for the last 5 days, so I'm now extremely vulnerable to COVID. But like you, I've had 3 PCR tests, and they well know me at the test centre. So we'll move on and see what happens tomorrow, Councillor Wilmot. Thank you. So, declarations of interest, members. Do we have disclosable pecuniary? Anybody? Excuse me. McGrath, Councillor.
Obviously, my daughter's training to be a nurse is one, but I'd like to put on record my thanks to Dr. Foster, who a couple of meetings ago, around the mental health side of things in Nottinghamshire. The lady actually contacted me as thank you to you, Martin. I got hold of the lady, and I believe her help helped one of the families who we talked about. So I'd like it to go on record thanking Dr. Foster.
Thank you.
Thank you
you
very
very
much.
much for that comment. Thank you. Private interests, please. I will just give a declaration that my daughter works at the Queen's Medical Centre. So,
Chair, I am on the committee of the Wyburn Medical Practice.
right, okay. Okay, fine. Thank you very much. So, I think we can move on now, members, to our first item, which is Nottingham University Hospital's maternity oversight. And we have Danny Burnett. Hello, Danny, can you hear us?
I can, loud and clear. Good morning.
Good morning. I feel you're speaking to us in very difficult times at the moment, and I think you will feel safer where you are than possibly coming in to see us, who are all coughing. Thank you very much for joining us. Would you like to give your brief?
Yes, of course. So good morning, Chair, good morning, committee. My name's Danny Burnett. I'm Deputy Chief Nurse at Nottingham and Nottinghamshire CCG, and I'm here on behalf of Rosa Waddingham, Chief Nurse. Thank you for also accommodating the Microsoft Teams today. I am currently, so is Rosa, supporting the vaccination programme. So it allows us to be sort of dipping in and out of the vaccination programme, and I'll be joining one of the pop-up centres later after this meeting. So thank you for that. We've been invited here today to talk about NUH maternity oversight arrangements. I'm not going to go through the paper that's been presented in detail, and I'm just going to pull out some poignant parts and then allow questions and answers if that's okay, Chair. Excellent. So what the paper is aiming to do is illustrate both what we have in place today in terms of oversight arrangements, but also what we are intending to do as part of the transition following the statutory changes that are afoot and have been slightly delayed because of the current pandemic and situation and response that the system is under in terms of challenges. But the transition into the Integrated Care Board and that being established. So ultimately, we know that we must ensure that we have to continue to play an active role in ensuring improvements for our maternity services and for our women and families. We work closely with regulators, NHS England and Improvement and CQC to ensure that there are clear governance and escalation mechanisms in place across Nottingham and Nottinghamshire, and that being in place for NUH, whilst not overburdening NUH. I think that's really important because what we can create is we've got a system of full of regulators and people that actually quite rightly have an interest in maternity services. So it's really important that we streamline, we're really clear, we're working towards one version of the truth, one set of data, one narrative. So that's been really important to absolutely get that right. So what you see in the paper is something that has been co-produced, co-designed, not only with our regulators, but also with system partners. The oversight arrangements that are currently aligned to the National Quality Board framework. So we're all talking the same language. And what it's absolutely trying to do is build upon an open and transparent approach to both planning, improvement and quality control. We know that following the publication of the CQC well-led review for NUH, we know that, again, we've got themes in maternity services that we see across the wider organisation in terms of culture, learning, governance. So we have refreshed our governance arrangements, and you'll see that highlighted within the paper. And the maternity subgroup has been established underneath an overarching NUH quality assurance group, and that met before Christmas. So that's highlighted in section or paragraph 2.2. So sat within the maternity subgroup is not only the regulators, ourselves, the CQC, NUH and their executive team, plus sort of senior representation from maternity services, but we also have Health Watch, Health Education England, local public health, and other system partners. The meeting before Christmas took an absolute focus around safe practice, absolutely poignant, particularly based on the current extraordinary challenges that are faced and are well rehearsed both nationally and locally in terms of the staffing, etc. 2.5, paragraph 2.5, and I think that's really important for committee, refers to significant progress in the presentation of data. So I think what we're starting to see that we haven't necessarily seen over the last 12 months is a real difference, a step change. So NUH really starting to understand their data, do that triangulation. And actually what we started to see, particularly around safe practice, is a better presentation, them understanding. So when they're talking about improvements, say around fetal monitoring, them describing what that means in terms of outcomes for women, for their babies, but equally what that means in terms of the wider service. There were also improvements in terms of antenatal risk assessment and what changes were being put into place. Pay still continues to be a focus for NUH maternity services, not only for us, but for NUH themselves and system partners. And we know that the pressures that we're facing are having an impact in terms of that pace, but we still continue to work with the Trust. Staffing, COVID infections, and the vaccination programme have been a particular focus in the last 8 weeks. And through both the oversight arrangements plus the local maternity and neonatal system, we continue to seek mutual aid offers to ensure that the system is taking action to support NUH maternity services. I think what's important here is what's different. So I know that if I was sat in your position, I would really want to understand, okay, that's great, Anna, you've explained some of the oversight arrangements that's in place, but what's different? This isn't a sort of a whole list, but I just want to pull out a few examples. Firstly, as CCG reps, we attend, we sit, we're invited, and we participate in so many more internal NUH meetings. So daily Safe Today calls that have absolutely focused on maternity safe today. And if we need to escalate, we'll have a 9:30 call, we will join the 2:30 call. So we're absolutely putting that challenge in where actions aren't moving or they're not quick enough, but equally we will take actions for ourselves as well to think about what additional system support. There are 3 times weekly incident review meetings, which we are invited to. So that's part of really defining sort of the scope of incidents, really thinking about the assessment of harm and putting in the challenge there. There is an NUH maternity improvement programme. We sit as part of their fortnightly programme meetings. But not only do we sit in those programme meetings where that programme is defined in terms of safe practice, digital, HR, but we also attend their trust-wide quality and safety internal meetings to really see how that's translated throughout the trust. So it's not just within the maternity directorate, but equally translated into their executive team and their executive team participation, and really trying to engage that sort of narrative that I've described earlier. We've also committed, so what we have is subject matter expertise. So we have midwives that sit within our CCG that can equally offer that challenge. So these are people that come with experience, they come with knowledge, and they're absolute part of that ongoing day-to-day. Secondly, the system response. So that this paper absolutely talks about this is not just about an NUH issue to resolve. Yes, ultimately they are accountable. They are absolutely accountable for the delivery of services. But as a system, we have a responsibility and we need to hold the mirror up to ourselves. So what we will also put into place is something called a quality insight programme. So we go on regular insight visits and we very much go along. We are assured by what assures you. There is no point us going into NUH, doing a report, giving them a report going, well, here's some recommendations. Actually, we need to walk the floors with NUH staff. You know, what does good look like, and really starting to drill down there. We also take system partners on those quality insights. So we take representation from Nottinghamshire Healthcare Trust, equally to really add some objectivity and independence into these quality insight visits. Key lines of inquiry are developed as part of those insight visits to really make sure that we're focusing in those right areas. Thirdly, Donna Rockenden, the nationally reported sort of a set of recommendations, has really raised the profile in terms of maternity services. We talk about maternity and we talk about neonatal services in the same breath in Nottingham and Nottinghamshire. But what it does is it really gives maternity and neonatal services a space in the system. The LMNS, the local maternity and neonatal system, have evolved. There's much more responsibility, and that has started to be put in place over the last 12 months in terms of something called perinatal surveillance. So that's reflected across the region and into the national team. So it means that even though we've got this enhanced surveillance at NUH maternity services, we also have maternity services, Sherwood Forest, and equally within our sort of community sector. So it's really important that we have a framework in place to go in terms of going forward. What the LMS also offers is some independence in terms of serious incidents. So there's a serious incident panel that reports into the perinatal surveillance subgroup. So it gives, again, that independence and objectivity. And then equally, some of the other areas such as digital and the Maternity Voices partnership is what the LMS can bring. Fourthly, we have the surveillance framework that's within the paper that talks about the quality assurance groups that are in place, and it provides that escalation both into the system space, but equally into those commissioning responsibilities. And then also, I just want to highlight sort of the fifth thing, and that's the absolute commitment to drive rapid improvements. And I know that committee would have seen information around the independent thematic review in terms of maternity services at NUH. We are not going to wait for that report and that thematic review to publish, but we continue to work with that. You know, we keep very independent, but we continue to work with the programme team to ensure if there's learning that's being identified as part of that thematic review, that we're absolutely implementing that at pace with NUH. That commitment is CCG and jointly commissioned with NHS England and NHS Improvement. But we absolutely want to ensure that every stone is lifted, that every sort of improvement is taken in terms of maternity services. I'm going to pause there, Chair, because I don't want to get into too much detail, but I just wanted to give you an insight in terms of the oversight arrangements that are in place today and the plans for going forward.
Thank you very much. I apologise, I was coughing a little bit in the middle. Bearing in mind the problems that you're experiencing at the moment throughout NUH, and I'm referring to the fact that you're going to be short of staff with COVID. It's a sure fact. How do you feel maternity can move on at the moment? Will you be making satisfactory progress? Obviously, it's going to hold you back somewhat, I would have thought.
Yes, absolutely. And I think maternity services are not unique in terms of the challenges from a COVID perspective. But what we do know is that maternity services were already on the back foot in terms of staffing. So their establishment was not where we want it to be at all. It hasn't stopped any of the recruitment campaigns. So we're very much continue to be briefed in terms of where they are with their recruitment. The daily Safe Today calls gives time, so it gives them time on a daily basis to talk about how they're mobilising staff, but that continual risk assessment in terms of those services. So when they're talking about face-to-face, sort of what they have a significant number of women that are on a COVID virtual ward. So they're caring for women in a different way, but in the safest possible way in terms of COVID. And when we're thinking about things like home birth service, etc., it's about trying to create a service that can deliver safety today. So in terms of some of the improvements, it does put some delays, but it hasn't prevented everything stopping. So actually some of the solutions are actually around looking at some of the how we can do things differently, and not just about how we can be more efficient. So it's the COVID virtual wars is absolutely given as an example. The vaccination programme has also really helped with some of the targeted work where we know we've got sort of areas of social deprivation, etc. So it's through every contact counts, and I think that's been really important as well. So yes, it is going to have an impact in terms of pace, but actually what I'm not necessarily seeing is a step down in terms of the maternity improvement, because a large part of the maternity improvement programme is around safety, is around culture, and it is around leadership, and you need all three of those to deliver a safe service.
That members of this committee were actually, I think Martin, our officer, was going to arrange for some visits to both Queen's and the city site, but they're going to have to go on the back burner for some considerable time, I think. please don't think we're not interested. It's just that obviously we can't come at this particular moment in time. So thank you for that. Members, any Councillor Barney, Vice Chairman.
Good morning, Danielle. Thank you very much for that in-depth covering of what's been going on, and I'm very reassured to hear that the CCG are meeting much more regularly, and so it sounds from what you've presented that you're very involved, working closely probably with Sharon Wallace and perhaps Michelle Rhodes as well. So that's all fantastic news. As the chairman here said, we are very committed to the improvement programmes as a committee. And this is a cross-party committee. We're all very much in support and wanting to see changes at NUH. And of course, it's on record the very clear calls that we've made for improvement as a committee with the NUH Trust and the maternity services in particular. So, as I say, very positive that the CCG are seeming to believe that there are credible changes afoot and that there are motions in place to make those substantive changes that absolutely need to be made. I just had a couple of questions that I wanted to ask. First of all, you mentioned about the triangulation and the data, which is, of course, something that CCG have picked up on going back over numerous months now. Have you seen the maternity dashboard, and are you satisfied that that's working, and is that now embedded with the staff from your perspective and the CCG's perspective? Also, you mentioned staffing. This might be a question for the likes of Sharon Wallace rather than yourself. But do we know where we are with those numbers? Because we were promised to see the numbers from about an 80 or so shortage being reduced to about a 30 or so shortage by November, I believe, last year. It'd be fantastic to get the actual figures on that to give us the reassurance that we would like to have. And finally, this is a personal question, and one that you might not like to answer, and you don't have to if you feel that's the case. Would you feel safe at the moment taking yourself into those services, or a member of your family in the maternity services in Nottinghamshire?
Yes, thank you. Okay, let's so do remind me if I've not answered all of your points. I'm just trying to remember where the first one is, and sorry, my pen ran out of ink. So
maternity dashboard? No, not at all.
Dashboard,
No,
yes,
don't be silly. It's not a
dashboard.
problem. So the maternity dashboard, yes. So on the data collection and the triangulation of that data, and then also how that's embedded, how that is being played out with the staff. Have they got the access that they require right across the midwifery services? So we're talking in the hospital, but also out in the field with the maternity care, district maternity care.
So yes. So in answer to your question, yes, I've seen the dashboard. Actually, the dashboard has got, it's been in a very iterative state. I think where we started off probably about 6 to 8 months ago was a very one-dimensional set of figures, which really didn't tell you a lot. So actually, if you were to really look at those figures, you'd be there going, well, have we got any outliers here? Where do we need to focus? There's lots of information here. Where do I start? And actually, what the Trust have been able to do is really start to think about that in sort of an SPC type of way. So it's really looking at statistical significance. It's really looking at change. It's looking at information that is very real time, absolutely appreciating that some of the information isn't validated, but knowing it's really needing to understand the data. They've been working with the national teams, and the national team's got a national maternity programme, and they're equally setting up a dashboard. So we've got things such as the maternity data set, so maternity services data set, and actually there's been some triangulation about what how those dashboards have been developing and what we can learn from one another, and that actually engagement still continues, and it's actually been a lot of positive feedback coming from the national team. So that's been really positive. I think one of the examples that I can give, so just before Christmas, the Trust did a session with their consultants. So I think one of the things that we've got is we've got a dashboard, and quite rightly, your question is about how are the staff using it. What we haven't necessarily seen is the staff really starting to embrace what's the data telling us, because what they're looking at, whether that be sort of from a consultant looking at their caseload numbers, they're looking at it on an individual one-by-one basis, and they're not looking at it as a service, really starting to have that sort of umbrella look. And there was a session just before Christmas with the consultants that went really well. And I know that from feedback from the programme director, and actually some of the prep that we were able to do as a CCG about, what the data, with the key lines of inquiry that we would be asking based on that dashboard. What the Trust are doing at the moment is taking that dashboard, because it's massive, and really starting to get down to the detail about what needs to go into the executive team to really help the executive team to focus on the areas that are important to do so. So it is still in development. Yes, I've seen the dashboard. I've definitely had feedback in terms of the consultants. I myself have, from being involved in the maternity improvement programme work and sitting at their oversight, I'm hearing the midwives, I'm hearing sort of particularly some of the matrons really talk about the data in a different way, and they're utilising that at their daily Save Today. So it's work in progress. It is there. I think what we're starting to see is really looking at the data in a much more sort of three-dimensional way or two-dimensional way, rather than the one-dimensional dashboard that they had about eight months ago. But they're really starting. The data that they're seeing is the same data that we're seeing, which is not where we were at the start of this programme. So I think we've got sort of a positive in that respect. Your second question, staffing.
So that might be a question for Sharon Wallace. We'd just like to know where we're at in the projections that we've been presented now over many months, whether we are coming anywhere near what we've been told. So we would expect by now to, I think, see a shortfall of around 30 frontline midwife staff.
Yeah, no, and again, I think it would be Sharon that would be able to give you the absolute figures around the staffing. The feedback that we had at the last oversight, so through the quality assurance, was staffing is still a significant challenge. That we're expecting a large number of midwives to start over this Q4 period, but at that point they were not on track to achieve where they wanted to be at the end of March, and it was the end of March 2022 that we were looking at, so looking at the 73 whole-time equivalents. I'm really thinking about how they're utilising their skill mix in a different way, so their maternity support workers, etc. But it's just been a significant challenge anyway, just about the current situation. But it would be Sharon that would be able to give you those exact numbers around staffing. We're not anticipating that they will achieve where they wanted to be. And what
we very much hope to be having Sharon Wallace back at a committee in the very near future, so we shall ask her that. And the final one was a personal question, which you don't have to answer, just about whether, how would you feel about a member of your family using the services in NUH maternity service as at the current time?
I think one of the things that I think it's important to note, so we've been doing a lot of work, and when we've been going and doing our quality insight visits, we speak to families. So we speak to families not only face to face, but we sort of engage as well through the local maternity and neonatal system through a variety of routes. We have had very, very, very few negative accounts of maternity services as part of our quality insight visits. What we've had is lots of feedback around kind and compassionate care and actually people feeling safe. That doesn't mean that that happens 100% of the time, and we absolutely acknowledge that. I think the quality insight visits are a measure, they are one measure. It is a personal question, and I do have a relative that is pregnant and accessing services at the moment, and I feel confident, and I would be using Nottingham and Nottinghamshire services. I wouldn't be seeking to go elsewhere. And I know from sitting on the daily Save Today calls and the approach in which they're taking safety, and they're thinking about safety in a very different way. I personally believe there has been a step change, and that would give me confidence if I was to be accessing services myself. And that is the reassurance that I am giving to my relative who is currently accessing maternity services at NUH.
I'd just like to say thank you for answering that so honestly and so openly. I think the committee really appreciate your answer. And I think, from the correspondence that we have, the chair and myself with people using the services, we're sensing the same, that there is positivity amongst the current users, but historically there's still a legacy of the past, which is where we're receiving most of the pressure and focus from. Very encouraging. Many thanks indeed, Danielle.
That's okay, thank you.
Thank you. Members, Councillor Wilmot.
Thank you very much, Chair, and thank you very much for the very informative report you've given to us on the improvements. Although there is some indications of improvement in the service, there's far more, as you have just said, there's far more to be done. At the last meeting, it was concluded that there was a lack of focus on impact and outcomes, and a lack of triangulation between the improvement plan, the maternity dashboard, and the challenges the service faces. And as I said, the commitment from the maternity leaders in the NUH to making the necessary positive change is commendable. And I have no problem with the nursing staff on the front line. But the question must be asked, what more needs to be done to permanently embed maternity improvement at the NUH? I personally feel more of a partnership approach should be developed, involving all sections of the service, including any users' thoughts, regular CCG representation, and in fact, in all the internal NUH meetings, there should be representatives from other organisations taking part. I would like to ask the NUH if they feel maternity improvement is moving in the right direction at the present time, and at a satisfactory pace. And what are the issues at the NUH regarding psychological safety and culture? Question 3 I've got, the transition to the Integrated Care Board is now taking place. What risk do you feel that could be negative on the NHUS situation on that position? And also on the NUH maternity improvement plan, how will continuity of oversight be assured? And how does the NUH, which is the Nottingham University Hospitals and NHS Trust, specific quality assurance and oversight framework operate? I would like to know that. Within the appendix, paragraph 2.9, it states, while the situation at the NUH is far from where it wants to be, or where we want it to be, can you outline specifically the weaknesses that need improvement and comment on whether parents are still receiving a poorer standard of service and babies and mothers' lives are still being put at threat? Thank you very much.
Thank you, Danny. Did you have a pen to write all that down?
I did. I've got a pen that works now. Thank you very much. Okay. Thank you, and thank you for those sort of questions and sort of observations, and actually ones that we too ask ourselves. So actually, none of this none of this is a surprise at all. The first point in terms of co-production and being sort of collaboration and partnership has been the absolute that we've been trying to drive in the last 12 to 18 months, working with NUH, not just in maternity services, but much wider. And I think actually we have got a much better relationship working with NUH. Some of the examples that I can give are things like being part of their recruitment panels for their senior midwifery posts. So their head of midwifery posts that they've got out for advert at the moment. We sit as part of the stakeholder panel, but also part of the interview panel. We have regular catch-ups, so that sort of investment, and it's quite warts and all actually when you're part of all their maternity improvement programme and you're sitting on all their internal groups, so whether on their incident review groups, etc., because actually they're not having an opportunity to talk about actually some of the contextual stuff, and they've got external people really joining those meetings, and they're not afraid to do that. They're absolutely open. They're absolutely open to our observations and welcome contributions. So we're being asked to contribute into, whether that be an assessment of harm in terms of an incident, whether that be around some of their planning work. So I would actually say that our sort of co-production, our co-creation, our co-design is absolutely there and will continue. I think in your question, you talk about how you then sustain that as well. And that feeds into sort of the query around the ICB and the establishment of the ICB and what risk that might bring. I think before we were in this sort of enhanced surveillance for NUH maternity, we already had the establishing local maternity and neonatal system, and we had a subgroup that was focused around Safe Today. The challenge was it was around, well, why would you bring some specific provider issues into a system space when you're trying to talk about improvements and transformation? Well, actually, you can't do transformation without really understanding what the current challenges, issues, the wishes of the public, the sort of that real sort of granular detail. And that's been something that we've been trying to transform over the last 12 months as well. So actually, that's been a completely aligned, that piece of work. to really think about how we bring system space really into sort of the future. So I think in response to your first question around relationships, I think we absolutely have got that. That has been demonstrated and illustrated through not only our attendance at the internal meetings, but actually when we go into the system space or the regulatory space, we're talking about one narrative. Actually, this is where, you know, the presentation that we've done today, there isn't something that NUH would contest. And equally, if NUH, and when they come into the future meeting, actually there's no surprises. We are absolutely joined up in terms of that narrative. The psychological safety that we've referred to in the report is something, again, that we're discussing with many services, maternity being one of them. And some of that is around when you are in that system space, how do people really feel like they're going to be held to account by their peers? And it goes back to that warts and all. How can we create an environment that actually NUH can go, I've got an issue here and I don't know if it's an issue, but I want to talk through it and I want some sort of support. And I think that psychological safety within that ward environment, i.e. when there are sort of incidents, it's creating a space where actually, yes, we are under pressure and we've got all these, we've got all this work and we've got the operational demands. But actually there was an incident and I do need to report it. And how do we create that? And NUH have, you know, we've got nationally this PMA model, so this sort of midwifery advisory support, what was the old supervision that's evolved to really help with that psychological safety. And that has had some real positive impact in terms of the trust and how that's then embedded across NUH. And we hear that as an external partner. So when we're going in and doing the quality insight visits, the staff will talk to you about their PMA sessions. They will talk to you about actually, I contacted the PMA, they got back to me within 15 minutes, and this was, you know, this was what had happened and the events that had been put in place by the next day. So I think that psychological safety is part of that cultural change. So it's about not only at ward level, at exec level, but equally in the system. How do you create a space where it's okay to say you're not okay? It's okay to say, I've got a concern here. It's not, you know, we know that we've got sort of the freedom to speak up and we've got the sort of the managerial and the leadership options, but psychological safety is about that shared governance. It is about sharing risk. It is about creating a space where you can absolutely create that open and honesty. And we're doing that. We see that within the NUH and we're doing that within the system space. The risk to the sort of the ICB and the challenges is actually, I think that what we've presented today is what is going to be in place come the ICB. So, you know, when the ICB is up and running, actually we feel we're already ahead in terms of really establishing a really sort of strong governance arrangements. So where we are with NUH and NUH maternity is what we would have seen. So when we were in sort of the post-mid staffs and we talked about what were quality surveillance groups were there and they were set up to talk about soft and hard intelligence. But at the time and when they were established, they never had providers in the room. And there was very good reasons for that. But equally, what we've done in Nottingham and Nottinghamshire is we've brought the providers into that, absolutely that QSG, what is now our own sort of, you know, we're using our own language into that space. And that's where psychological safety is absolutely important, because as commissioners and as partners, we all have our own version of events. So we're doing a lot of sort of work in the background to make sure that we've got our dashboards and our numbers right and our data right. So when we do go into that system space as part of the ICB, we're absolutely joined up in terms of understanding where our challenges are and what we need to do about it. What are the actions for NUH? What are the actions for us as system partners? And what do we need regional and national support with? So that's really clear. So I think actually for me, I feel very confident that going into the ICB, I think actually what NUH maternity has got is this extraordinary surveillance model, which if we were in a very different position, so if I take Sherwood Forest, who's within our patch as well and got maternity services, we've got the LMNS, the perinatal surveillance that I described before, absolutely looking at the same thing, but in a sort of an LMS system space, but not necessarily getting down to the granular detail where we are with NUH. when we get into a position, and it will be when we get into a position with NUH where actually we're starting to really see those improvements, those quality insight visits aren't going to go away. They are absolutely here to stay. So what we're learning from the NUH work will inform the local maternity and neonatal systems perinatal surveillance going forward. So maternity will be at system, there will be a vision, there will absolutely be maternity oversight at system level. And that's what Donna Ockenden absolutely described, and that's what we're already developing. So for me, the risks are absolutely there when you're moving into new statutory functions, but I feel that we've got something really strong set up, ready to go into the ICB.
Thank you, Danny. Has that answered all your questions, Councillor Wilmot?
Yes, thank you very much for a long and a very informative answer. I say we shall all be looking forward to all these improvements taking place, and hopefully, you know, the improvement will continue. Thank you.
I was going to ask you, Danny, clearly you can have all the dashboards in the world and all the data around you, but when is the ordinary, everyday person going to see real improvement at NUH in the maternity services? When is that changeover going to be? I mean, it's obviously going to be gradual, but I had reason to go into Queen's just prior to Christmas with my grandson, and on the walls is your CQC rating, inadequate, and it looks terrible for people coming into the hospital. And I just wonder when we're going to see a change where people can actually come out and say, gosh, it's so different in there.
Yeah, in terms of maternity and maternity services, I know that there's initially we heard 12 months being talked about in terms of moving from inadequate to outstanding, and actually we knew the sheer scale. You know, as CCG, we knew the sheer scale of the programme of work that was needed to occur. And I know that when we're looking at other services across the country that have had a significant amount of scrutiny, it's been years of really trying to get down to some of that detail and that improvement work to really start to make the sort of the tangible, noticeable changes to you as a member of the public that would be walking the floors and accessing services. And I would say that there's something around addressing what CQC found, but there's something about addressing maternity services and really make it, you know, doing that step change and making some of those transformation and improvements that we've been talking about nationally for some time. And I wouldn't want to put a time on it at all, because I think it's really important that we get this right and we get a sustainable service. So we get something sustainable. And you're absolutely right. You can have all the data in the world. The problem is it's about what you do with that data and how you understand it and how you work with your families to really shape services around, you know, the things that are important to women and their families. So when we're talking about things like continuity, actually it's not necessarily always having the same midwife throughout the whole of your journey, but it's about, you know, those antenatal and postnatal periods, and really about getting that right. And I think some of the work around what we're doing around digital in the local maternity and neonatal system, which NUH have a real sort of important stake in, they're the sort of step changes where you go, actually, we are starting to see maternity services transform. So I think where NUH are is some of it is reliant on some of the transformation, as well as addressing some of the absolute fundamentals of care around staffing, around sort of psychological safety and safety, creating those sort of safe ward environments, and how they're doing that on a day-to-day basis. So I wouldn't want to put any time on it about when. I think what we continue to do is it's not just about having a look at when we get the negative feedback. It's about how do we get more of the positive. So what was it that you know, when we're getting a positive feedback, what was it that made a difference to getting that right that time? And I think that's that's the work that we're doing as a CCG to help, you know, with NUH about what does good look like, and really starting to shape that sort of work as well.
Councillor Welsh.
Hi, thank you. I just want to thank you as well for your answers. Without being disrespectful to anybody else that's come here and spoke to us about maternity services, I do think that yours has been the most thorough and transparent. So I really do appreciate that you've come here and actually been able to share as much information as possible, given the current situation as well that you're facing with regards to the rollout of the vaccination and everything else that's going on. So I won't take up too much of your time. It's just some clarity really with regards to data. So you've spoken a lot about the data, but what is this data exactly that you're actually capturing? And is it also monitoring other things such as socio-economic group, race and ethnicity? So that's one of my first questions. And how does that data differ to the data that should have been captured for the last 10 years? So that's my first question, because we spoke about data and you said this improvement. Well, we are a health scrutiny committee, and at some point it would be really useful to see some of that raw data. Not because I'm not saying that what you're saying isn't right, but I think it would be really useful for us when we're talking about this outside of this room as well, and also for us to make informed decisions as a committee. I think also, Chair, and I correct me if I'm wrong, were we not promised a certain dashboard to come to this meeting? Has that happened? I recall being at the last time that we discussed maternity services, where they said they would share the dashboard, that it wasn't in public view at the moment, but they would share it with us. I may have seen it and gone through Christmas and forgotten about it, but have we had any of that information? I'll go through first. The other question is, there's an agreed local maternity system transformational plan that is still online, suggesting this is the maternity plan for NUH that goes from 2017 to 2021. I'm assuming that needs to come down and it needs to be replaced with what the new plan is, because 2017 to 2021 plan, if you read it, systematically failed. So that does need to be replaced or looked at, because it's that communication with regards to what information is out there. Sorry, I will stop. 2 more questions or 2 more points. With regards to capturing the data, I think you touched upon this, but I'd be really interested in getting some more information, if now's not appropriate, but elsewhere. How do you capture the scenario, for example, I phoned up maternity department to say that my contractions started and I was dismissed by the person that I phoned to, and they didn't even look at my file. How is that captured and how is that being captured? Because sometimes that can happen. I know that it can happen. And then you go in and you have an all right birth and you go away and you say, how was your service? Yeah, it was great. And you forget about that initial bit. So it's those initial kind of, not anecdotal, but those things that actually are really, really important. How are you capturing those and how are those feeding in? And then last but not least, the independent inquiry, when you phone up and speak to them with regards to the independent inquiry, they take your details, they take some information, and then they say that you must now go to PALS and refer your case to PALS. So my question is, if you are talking about capturing data and acting on things that are taking place here and now and what is going on, how is that data, how are you capturing that data from PALS as well? So I've got 3 cases, for example, in the last 2 weeks that have gone through that system and gone through PALS, but I'm not sure that you as a CCG would necessarily know about those cases, and I think it's fundamental that you do. So that's my other question, is it's kind of joining those dots between the inquiry, PALS, and yourself, which is actually vitally important if you are to make those improvements as you go along. Last but not least as well, you talked about digital, and we had quite a big conversation with that previously, and I know Councillor Adams actually mentioned it as well. The systems that the community midwives use have historically been different to what is used in the hospital. When I went through that system, I have to say I was shocked that my consultant didn't know, unless she got out the paper file that I carried around with me, what the community midwife was saying with regards to it. Has that all been joined up? Because that to me was absolutely critical to join up that digital system. And I know it was something that the CCG were really, really keen on, because it gives them that overview as well, and everything's kind of in the same place. So that's it. Sorry, one more question. Sorry, one more question with regard. The other question with regards to COVID, and we've talked about the impact on maternity services anyway with staffing. And we're hearing at the situation at the moment, we've got staff shortages because people are having to isolate because of COVID, etc., etc. Are maternity services being prioritised at NUH? And the reason I ask this is because when the first lockdown happened, health visitors and midwives were often directed to other services to help with what was a national situation. So what I would ask here is that, given what has happened in the maternity services in the past, given the current staff shortages, the maternity services at NUH are prioritised, health visitors and midwives are not directed anywhere else. And I know probably every department in NUH is going to say the same thing, but given the situation and given the seriousness of what has happened previously, I think if we could have some reassurance on that, that would be really, really useful. Sorry if that was a lot of questions all in one, but that's what happens when you put me last. You see, I get everything from everybody.
That's
Danny.
fine. Thank you, Chair. Let's. I've tried to jot down as many, so do remind me if I've not answered all your points. So in terms of the data, it has been really, really challenging. Largely because a lot of the data that you would have seen, and that equally we would have seen as a CCG, is it feels out of date, and so it's largely based on published data, which some of it can date back to 2017, 2018. So that makes it incredibly challenging when you're looking at a dashboard that has all different timelines. So you've got some data that's this year, some data that it dates back a couple of years. So this system's not unique to that. So NUH are not unique to that. That has been something that through the establishment of local maternity and neonatal systems, that they've tried to actually draw upon how they can get real-time information that may not be publicly available, but that they can absolutely track whether some of the improvements, so some of the projects and programs, are actually making the necessary changes. So in terms of outcomes, we're looking at the outcomes. So data has been a really real hot topic for not just NUH, but wider for the system. What they're looking at internally, and I think some of the dashboard that you've asked for from the NUH would be helpful, is to have sight of actually looking at all the indicators, because I think typically what you would see are things like number of births, number of twin pregnancies. So it's sort of all that general feedback, but actually what committee want to see are looking at it's the outcome measures. Actually, what are we seeing in terms of sort of the the challenges? And I know that question around when you said, we're looking at the demographics, that's where the LMNS, so the LMNS are developing a dashboard. It's separate, but in line with and co-produced with NUH. And part of that is the work that we're doing around the equity strategy. So we've got to have an equity strategy in, and it should be sort of co-designed and co-produced, ready for sort of January this year. That timeline is going to slip a little bit because of sort of the COVID pressures, but that absolutely brings in the demographics. It looks at populations. It absolutely looks at outcomes. So that's going to really complement the discussion internally within NUH. And we're working really closely with their data analytical team to get that information right. The vaccination programme has also given us the opportunity to look at that demographic data. But when I referred to earlier that conversation around the consultants, what are we doing around consultants, and how are they not just looking at, say, postpartum hemorrhages or caesarean section rates, but how are they looking at postpartum hemorrhages for BAME and all that preparation and that risk assessment work, which they're absolutely doing well. So how do they start to talk about their data in a different way? So I'd say that is work in progress. It is something that it moves from that one-dimensional look at data But data is a real challenge, and it is a real challenge for us to get that sort of cohesive. The commitment that we've made is, as an LMNS, we want to get a sort of a public-facing dashboard out there, something that we feel really confident with. But actually, we start to tell this the sort of story in terms of that public story around maternity services, but a more up-to-date story that is going to be really real for people. But equally for NUH, how do they start to layer in some of that demographic, that outcome, those outcome measures? And I think some of the work that we've done through sort of our systems analytical unit will absolutely help us. So we're not there yet, but we're absolutely looking at everything that you've described in terms of looking at that data. That dashboard, I think it will be important for you to see, so you can start to get the confidence yourself. So I can talk about it because I've been part of helping to shape it. I don't see, or I don't get the final document at this point in time, because it is work in progress. But through the quality assurance group, that subgroup, and that sort of the group that we described at the start of the paper, we do get snapshots of that information, and that does come through to really look at those changes. So we are starting to see that more through that quality assurance process. The 2017 to 21 strategy, you're absolutely right. I'm assuming, is that the LMNS strategy or the NUH strategy that you refer to?
It's the LMS strategy.
LMNS. So I think the work around the equity strategy, we've also had the long-term plan, so the NHS long-term plan, and we've refreshed sort of trajectories. So there is some work to do, and I think some of the what's prevented that being updated, so an updated document, has been some of the COVID operational challenges to really get that sort of one updated version that reflects the future, the beyond the 2021 sort of going forward. But we are absolutely working as a system to get that refreshed. So we will get that updated as soon as possible. But we've been working with the Maternity Voices Partnership, with all our partners, to get that. So I will go back and to understand why we haven't got the updated version on the website. So apologies for that. The example that you give around triage, so your own example of when you call triage and that sort of PALS and that triangulation is absolutely right to flag. And I think one of the things of us not only sitting within the maternity improvement programme, but on the trust, is we get to see complaints, PALS, etc., at a much wider scale. So you do that triangle, because you don't always connect that to be a sort of maternity services issue. And so it's really important that we can do that, but we need to see NUH doing that, and that's exactly what we are starting to see. How do we get that triangulated? And I know that you give an example around sort of the independent review. The independent review team, I understand, are doing a series of engagement events with families at this point in time, and those are being scheduled over the coming weeks. So that is very there, and I think some of that triangulation will be fed through from the programme team. So some of those themes that they're also hearing. So I know that you've been signposted to PALS. That doesn't mean that will be lost. And the programme team, we anticipate, will absolutely be feeding those themes through into us as well. So we do get the information through the CCG route. But going back to the data, it's important that when they're looking at the sort of the indicators, that they're absolutely not just looking at the complaints, they're looking at sort of the PALS and everything else. So again, that's just as important. The digital, so the response around the digital, there is one system now, so they're all on Medway. That is in place and that is resolving. Obviously, they've got system updates that continue to be put into place. But I think that's sort of we put a bid in as a system, which NUH, we're really integral to it, trying to get some additional investment to get our digital services really fit for the future and fit for now, because we do feel behind the curve, and hopefully we will be successful in that. But you're absolutely right to identify that, as that was a real critical thing, particularly around continuity of getting those systems all joined up. Preservation of staff, particularly in this COVID climate, and how are we prioritising? Not only are maternity services absolutely being ring fenced, so there's no redeployment from maternity services across any of our services. That we are are aware of, and in fact we're seeing the absolute opposites. So we're seeing mutual aid coming in from our nursing teams, etc. So we're seeing that as very sort of real life and happening. But we also have a section on our system exec call that where we bring maternity, you know, how maternity services, we hear a lot about ED services, but how are maternity services varying. So it's not only talked about at system exec, so this is not just because NUH, you know, we're in this sort of oversight, but because maternity services nationally, again, we know about the challenges, and there absolutely are being ring fenced. And I think some of that word that we described about the vaccination programme, how can we get the vaccination programme supporting to get as many vaccinations in place as possible? So we are definitely seeing the mutual aid reach into maternity services compared to some of the other challenges that we saw in the first wave. Has that answered most of your questions? All of your questions? Apologies.
Yes, thank you. Yeah.
Thank you, Danny. Anybody else with any other questions, may I ask? Danny, there's two things I just want to highlight, and that is the value of this Health and Scrutiny Committee at Nottinghamshire County Council. On Christmas Eve, I received an email from someone who has had traumatic experience in Queen's Medical for the last 5 years. And she thanked this committee and wanted me to make it very knowledgeable to this committee that the work that is needed doing, looking into what is going wrong at NUH, she feels has at last started to be addressed, and begged us to dig well down to see what is going wrong, and thanked the committee for the work, and said that this person would continue to watch every Health Scrutiny Committee to make sure that we are really doing what this committee is set out to do. I did actually reply to her and thank her for her very interesting email and pointed out, as I do to everybody, that the committee, the purpose of this committee is to draw together everybody's problems, concerns, worries, whatever, bring it all together so that in the end we can formulate a response and a recommendation. But I just wanted to point out to the committee how valuable this committee is to the people out there. And so much so, I got an email on Christmas Eve telling me this and saying, well done to the committee. So I did want to pass that message on. My other concern, and I don't think it's necessarily you, Danny, but it is something that I'm really not going to leave alone. When we first came to this committee as new members in May of last year, we had Dr. Keith Girling talking about incidents. And I asked what incidents, and he couldn't relate them. Now, you've had a lot of incidents, and you've paid a lot of compensation. And I have those people writing to me. Now, what I would like is a list of incidents. How you organise it, I don't know. But you've obviously had major incidents which have resulted very sadly in deaths. You've obviously had medium incidents, and you've also had incidents which might just have been a machine going off for a second or two. We would like to know, as a committee, exactly the breakdown of those incidents so that we can look at a sheet of paper and see there were X number of major incidents, X number of major incidents, and what these incidents are. Because incident is a word that can mean anything. We want to know whether it was a baby death, whether it was a machine that went off, whether it was somebody who didn't know how to use the machine, whatever. And into columns, please, and how many, so that we can really look at it. Because until we have that information, and until we can understand what incidents were actually occurring, it's going to be very difficult for us to draw together conclusions on whether it's actually improving. Yeah. So I really would welcome that. please, for all members of this committee, and I think all members would probably agree with that. So could we have that?
Yeah. Yeah, I think so firstly, just in response to sort of the thanking of committee, I also sort of thank committee. I think it's always helpful to come into committee and equally be challenged. And I know at times we can try and be as positive as possible because that's where we want to be. We want to deliver a really, or have, commission a really positive sort of service for our women. And it's not where we want it to be at the moment. And we know that there is a significant amount of work still left to do, and we are committed to doing everything within our power to support NUH to make those improvements. So I really welcome committee's challenge as well. So I think that, and it's absolutely the right thing to do to keep us on our toes and to equally hold us to account for our involvement with NUH and maternity services. I think in terms of the incidents, one of the things that we'd asked of the independent thematic review is an absolute forensic look at the data and analytics. So it's really important to ensure that we're looking at lived experience, but actually what is that data? And it gets down to that granular detail. So the review team have been tasked with looking at data trends and management of all information since its inception in 2006 in order to assess those patterns of incidents over time and those correlating themes and trends and potential causal factors, because for exactly that reason, actually what we probably are a little bit more aware of are those serious incidents. So the NHS nationally defined serious incident definition, but we don't necessarily always have all the detail around those patient safety incidents, which is I think what you describe as those sort of medium and low, that that time that the machine goes off. So what the independent thematic review will look at is exactly that. So, are we getting this right? Because it can be really tricky because you can become much too granular in the detail that you miss the point. So we need to absolutely set the bar in terms of what we expect as commissioners in terms of the level of detail coming through. So I can't speak on behalf of the trust in terms of getting that on a sheet of paper for you today, because that is the trust's information. What we have oversight of are the serious incidents, and what Donna Rockenden absolutely reinforced is that the trust themselves should be and the LMNS, but the trust themselves should be now reporting publicly the themes and trends from their serious incidents, and the same for the local maternity and neonatal system. So we will be starting to ensure that we are equally reporting to the public the learning and the actions that we're taking from that learning in terms of the sort of the outcomes of the serious incidents. So I appreciate your question is much wider than serious incidents, and it draws a pin around sort of the coronial inquest, etc. But as a starter for 10, we know that we've got the independent thematic review. We know that actually we need to get this right in terms of what is the level of detail that we need to be seeing to ensure that we feel confident in terms of the quality and safety of care at NUH. But I think for that detail, it would be a question back to Keith and the team.
We definitely need, we keep asking for it. It's as if it's a closed thing that we can't have the information, but I shall request it every time until we actually get it. Because until we can see that babies are coming out very safely from that unit, to me, it's not safe. As long as somebody can go in and lose a baby, to me, that is not safe. Obviously, there has to be some risk, but not quite the risk you've been having. But we can't seem to get these details of the incidents. Yeah. It's as if there's some hidden data somewhere. It's not acceptable, and it has got to come forward.
And I think, Chair, just to finally say, I think it's really important, because I think you absolutely, in terms of seeing the data, but it is much wider than the data. It's the soft intelligence that we can do that triangulation with, because we know historically, sometimes when you look at data, not outside of maternity, you will have organisations and providers that wouldn't necessarily be triggering any sort of, we need to go in and do an investigative work, because the numbers don't necessarily, they're only part of the story. So it's so important that you bring that together. But yeah, we need to start getting that data right, so we can support that narrative.
That's lovely, thank you. I think I saw Councillor Cubley's arm raised. Would you like to speak, Councillor?
Yes. At the last meeting I attended, admittedly I missed the last health scrutiny. I did ask for the information on what is the total compensation to date being put out, how many cases that relates to, and how many cases have you got outstanding? Because I know in the news recently, BBC News, 2.8 million was paid out to one couple. So I did ask for that information, and have you got that information, please?
So that would be information from the trust themselves around the CNST and their NHS resolution. So in terms of total cost, we would need to get that information from NUH.
No. Well, yeah, I need the total compensation to date, the number of cases that relates to, because then you can get a mean average of what we're paying out, and then the number of cases outstanding in your in-tray, because then we can get a rough idea of, because, you know, because there's a lot of money that NHS could use for other things.
Councillor Cubley, NUH are coming back in March to discuss these sort of issues, and I think we'll ask Martin to absolutely ensure that they come back with the information on the incidents and the information on outstanding cases and compensation already paid. Would that be satisfactory to you? Right, Danny. So we'll do that.
Yeah, I think that would be helpful, Chair.
Yeah.
I think we have absolutely oversight in terms of the actions that they're taking in terms of their NHS resolution, their CNST. They have a number of standards that they have to meet, and we now have oversight of their sort of improvement plans. But in terms of that finer detail, I don't have today, I'm afraid.
No, I can appreciate that. So, Councillor Welsh.
I think it's a really good idea what you said with regards to Martin asking for the data previously. I think what would be really, really useful if we were quite specific in some of those requests. So one of the key things, what has been mentioned as well, I think to add to that, we need to be asking how many of those incidents were downgraded as non-serious incidents that then were upgraded after investigation. I think that is actually quite critical, because that is a data that we've been trying and people have been trying to get from NUH for a considerable amount of time, and that is very, very telling. And the reason that we do need that data is because that should be fundamentally important and a fundamental baseline of any improvement plan to maternity services, because that should never happen, and we should be making sure that isn't happening now. I know that extra criteria that NUH made up for itself has apparently gone, but I think that is something that as a scrutiny committee we really need to be aware of. And then the other 5 bits of data, which I think for consideration for you as the chair and the vice chair, would be, and I think to go back for at least 10 years, because this is how long they should have been capturing this data and should be publicly available, and it's not. So complaints about maternity services, stillbirths, maternal deaths, admissions to neonatal ICU and premature births. And I think we need to be really specific with those questions. There might be that there are more, and I think we certainly need to be asking the questions that have just been raised, as well as how many of those incidents were classed as non-serious incidents when actually they should have been serious incidents in the first place, because that's the bit about things not being investigated properly and not feeding into improvement. And it's really, really important. And I keep saying this, but I know this is raw data, and I actually agree that there should be a mixture of them both, which is what you said. But we need to get both sides right if we're going to see improvement. And unless we get that baseline data, unless we can feel confident that NUH are being transparent to us, I think we will always be will be on edge about what improvements are actually happening and how they are taking place.
Yeah, thank you. I don't think that is actually for you, Danny, but it is something you can appreciate this committee are very, very concerned about. We feel we're only on the outside of the information. We want to be right into the nub of what is going wrong. And trying to get that information is very, very difficult. You know, I appreciate people don't like to give bad information out, but if this committee is to do the job, that we are supposed to do, we need that information. And Martin will make that very, very clear when they come back next time, because if they don't bring the information, then we need to make it very clear to the outside world that for some reason we're not being given these figures and we need them. So that's how that you can see how strongly the committee feel about that. Has anybody got any more questions for Danny? Danny, thank you very much for joining us today. I appreciate that at the moment times are extremely difficult and challenging for you back at Queen's, and we're going to let you go. Thank you, and let you get back to your real day job of trying to sort out what's going on over there at the moment, and let's hope that you keep your staff healthy and they keep going for some time yet.
Thank you very much. Thank you very much, Chair and Committee, and thank you for this morning and the questions. Thank you.
And we do offer our thanks to all the medical staff who are working in extremely difficult times. So thank you very much.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you, everybody. I think we have Dr. Jeremy Griffiths, who's left his injections for a few minutes to join us.
Yes, Chairman, just to explain, Dr. Griffiths contacted the office this morning to say that he was going to attend in person, so I think Martin's just gone to fetch him now.
Oh, that's excellent. Yeah, I'll put my mask on. Good morning, Dr. Griffiths. Right, members, we have Dr. Jeremy Griffiths with us, who's come to speak to us, who is Vice Chairman of the Nottinghamshire Health and Wellbeing Board. Dr. Griffiths, we're extremely grateful to you coming in what is a very difficult time for you at the moment, but I dare say you'll enjoy half an hour without a needle in your hand putting into somebody's arm. So you're going to give us an update, I understand, into how our residents can access patient primary care. Thank you.
So, as I said, my name's Jeremy Griffiths. I'm a GP in West Bridgford, where I've been a GP for 24 years. I've been on the Health and Wellbeing Board since its inception, and Vice Chairman over the last 6 years. I also work for Nottinghamshire and Nottingham Clinical Commissioning Group, what's called a Clinical Design Authority, which is a set of GPs who work on clinical design across the system. I have a lead role around prevention, social prescribing, diagnostics as well, and also long COVID. I've been in my current practice for the last 7 years. It was made of a merger of 4 practices. And we're on Wilford Lane. We cover 17,000 patients, where we have 9 partners, 4 salary doctors, 4 training GPs at any one time. So I wasn't able to get to the last meeting when Dr. Short spoke, but I was asked if I'd like to come and talk to you about how general practice and my own practice is dealing with what is the single most significant public health disaster and emergency in our lifetime. That's as serious as it is. For us, it's meant a reconfiguration of our operating model almost overnight. And that's set against a background of the situation where a full-time GP was expected to look after about 2,000 patients, increasing ageing population, increasing numbers of long-term conditions, and we have about a quarter of our GP workforce that's over the age of 55. And we I'm very fortunate in so much as the building that I operate on is a modern building. There's obviously increasing amounts of expenditure on general practice, but not all buildings are not all modern buildings, which have, for us, that's enabled us to be much more adaptive to the what's actually happened. I think it's important to say that actually what we've seen as a result of COVID is a lot of changes in the way that the interaction between general practice and the community. I think everybody has gone into a disaster behaviour. It's slightly shaped now as we've gone. Now we're 2 years further down the line. But I think it's fair to say that we've, as a total society, there has been a collective grieving for what was the way that our society operated prior to COVID. We initially saw the behaviours of the public in so much as that they tried to protect their health systems, and some of the time that meant by not actually engaging to the same extent as they did before, and that was the protective nature of the community. But I think now what we've seen is the increasing pressures and the desire to survive in our community. I think we do see that. People want to get things fixed as quickly as they possibly can. We've had periods of time when there's been maybe less patience with our ability to deliver what's actually needed. We've certainly seen huge, significant changes in the amount of mental health problems that we've had. You know, I remember sitting in one surgery and have 3 consecutive patients talk to me about wanting to kill themselves. That's really hard to deal with. You know, but that was the reality of the situation. That it's actually meant that there's been significant challenges for our population. And we're also now trying to provide our services reacting to the demands of the pandemic, but also mindful of long-term conditions and protecting people in the long term. So, as I said, the operating model changed literally overnight. Huge amount of adaptive change in an already complex system. So we had significant changes in the amount of use of technologies. A lot of technologies that were rolled out literally, some even built in a weekend by providers. An alteration in the way that we dealt with what is a sizable burden of bureaucracy, of paperwork that is needed within general practice. Because it's not just about the PACEL consultation, it's everything else that's wrapped around that. There's an increasing public role of general practitioners and their staff. One of the first things that's happened in the last couple of years there's been the first rollout of significant numbers of new members of the primary care team since 1966. That was the last time there were any new roles within general practice. But what we have had recently, which I'll come on to, is our members of staff that work with us within the practice that are run by our primary care networks, such as our social prescribing link workers, and they had a sizable role in dealing with vulnerable people at the time of the initial peak of COVID, and are still highly important for us now in dealing with those people who are isolated and a little bit maybe more disconnected than the more mobile population. We've had to adjust the use of our buildings. Even what we wear is completely different to what we were. You know, we've had to become much more infection control aware. And one of the first things that we did is we adjusted the way that we deal with demand. Historically, what would happen is patients would call in, be given an appointment with the GP or the nurses, and we would just deal with the numbers. And I think there were increasing challenges with those in terms of the number of issues that, as people have, one of the great successes of our public health system and our healthcare system is that people live longer and longer, but as people live longer and longer, they have more and more problems. And there were already changes afoot about looking at how we actually deal with demand prior to COVID. So what we do as a practice is that anybody wishes to see a practice nurse, they just get booked into the system. Anyone who wishes to see a GP actually speaks to the GP beforehand. And what we do is we have a conversation with the person, and some of the time we can actually deal with the issue over the telephone. Some of the time what we'll do is we'll organise for them to have tests as opposed to bring them in and then do the tests. So it's a much more efficient system. And I would say about 40% of our patients we will see on a face-to-face basis. So that's the sort of numbers that we see. Sometimes we'll use text, sometimes we'll occasionally use video. But we're finding that there are certain things that we would have originally have brought people in for that we don't actually, we don't bring them in at this moment in time. And that can be useful for individuals. Some people find difficulty getting time off work, have got other things within their life. But they know that if the capability is there for us to actually bring them into the practice, then they can do so. But I'll talk about how we're developing that. We've also very quickly moved towards paperless systems, so electronic prescribing. We have software now that we use often for looking at things like rashes, or if people want to have things that they show us, or it may be the use of their patient's personal data that they've collected, maybe blood pressure readings, peak flow readings for asthmatics, diabetic blood tests. These sort of things, we can actually interact with individuals and pass information back and forth. Or, for those people who can't use technologies, and we have to accept that there is a generational effect. The use of technology is very different in the younger age groups as opposed to in the sort of war generation, if you like, post-war generation, and even some of the baby boomers. So we have to be flexible in the way that we use different models for different groups. Emergency. So the way that we run things is that we'll have on-call doctors, between 2 and 3 on-call doctors every day that deal with anything that people feel cannot wait till the next available appointment. Those doctors will probably deal with up to 50 patients in a 10-hour session. And that's an intense session. That's hard. People come away from that feeling exhausted. That's the reality of the situation. Of those, I would say about a third of those get seen face-to-face. We've adapted the use of our building so that anyone that we suspect has got an infectious disease uses a separate part of the building. So people can be using different desks and different rooms to see people. So that's been an adaptive challenge. The emergencies as well. The system there's been an awful lot of work done to try and integrate between ourselves and the hospital sector. In terms of even things like basic guidance, emergency telephone numbers that we can utilise to access care, the ability for our hospital colleagues to actually access our records as well directly, because it's not one big system. It is different software systems that have to talk to each other. And that can be a challenge. If our colleagues are busy, if systems are run by people, if people don't necessarily create systems that work closely with each other, then that can cause frustrations, delays, that sort of thing. But it's getting better, and we now have monthly online meetings with our hospital colleagues, and we're now moving towards developing an education system as well, with the hospital specialists as well. So these things have not been there historically. We've carried on being a research practice, and we've increased and thankfully the number of GP practices involved in research has doubled over the COVID period. We've also been involved in the vaccination programme, so vaccinating care home residents. I'll be leaving here and going to do a ward round in a nursing home that I look after each week, and we do the vaccinations there as well. Promote things like the NHS app, use of, we've developed our social media presence to try and communicate with the population as well. You may well be aware that there's been a move to develop the new, it's going through the House of Parliament at the moment, but the integrated care system that will also have integrated places. So the South Notts will be a place, City is a place, Mid Notts and Bassett Law. And then we have the primary care networks and GP federations, so much closer working together of general practices. Because originally general practices were individual clinicians who had somebody who collect the money from the patient. And then the practices developed into partnerships, and now partnerships are moving into wider networks as well. Because there's a recognition that scale is important, but also networking enables other things to be developed. And the development of primary care, the next stage of government development, has been very much here, has been very useful for management of the vaccine response. My own building is used at weekends for the vaccination programme. They've been involved in the management and the facilitation of the new staff that have come in, the first new staff into primary care. So physiotherapy. We have a physiotherapist that works with us in our 3 physios that work in our practice. We have prescribing advisors, pharmacists. We have a paramedic who's involved often with home visiting. And we have our social prescribing link worker team as well. And there will be a development of further staff as well going forwards. That may be things like dietitian, occupational therapy, etc. And GPs as well often GPs have portfolio roles, so they'll not necessarily work full-time as a clinician. I'm not a full-time clinician, I work 3/4 time. But I do a day a week of leadership roles in the CCG, and then the CCG has been very important in terms of dissemination of information. So every day, which was a new development after COVID, we now have a debrief session in the morning, looking at the latest guidance. So that's a half an hour. We'll get together, we'll take a bit of a roll call, because one of the things about COVID is that because of the rules around COVID, historically a virus, people would work if they felt well enough. At the moment, because it's a pandemic, that restricts whether they can actually be in the building. So often people are working remotely. If they feel well enough to do so, then people with COVID are working with laptops at home. But we have to work out if we've lost any members of staff temporarily overnight, and then an adaptive response to that as well. And leadership is absolutely critical. And one of the things that has been very good, the CCG, is that we've utilised software that means that we get the latest guidance and changes within the hospital system. that comes down to us, which we can then disseminate. There have been webinars that we do on a Friday morning, which have also talked about latest changes and adaptations. I managed to persuade the local hospital to do a newsletter, so that a newsletter has come out on a monthly basis, talking about changes within the hospital sector as well. And there's been increasing amounts of information. We've just got to make sure it's more signal and less noise, so it's got to be filtered. But the reality of the situation is there is an element of pandemic fatigue out there. Daily instruction changes, high-risk situations. At the very, very start, I remember going into a patient's house with a very high fever, not vaccinated, and walking out and realising that he had COVID, which was confirmed later, and actually being really very much aware of my own mortality. And that's not a nice situation when you're in your 50s. So there's an intensity about the work at the moment. There's greater decision making, probably within each consultation. It's not been easy. There's been, I remember one time going to a patient's house and very complicated patient, and looked at his newspaper on the side, and it was all about general practice needs to do more. Those sort of things aren't necessarily that helpful. But we've needed to be positive. We've needed to be adaptive, deal with the uncertainty, realise that this is a long game. We will have to live with COVID. COVID isn't going away. This is going to be part of it. And there's going to be this balance between when something is moving within our society to an extent that it's actually causing services to be under significant pressure, and when we can revert back to the new normal. Because it won't be a reversion to normal, it'll be a reversion to the new normal. What will the future hold for us? I think that we'll move towards a balance between utilisation of technology and increasing the amount of face-to-faces that we will be doing. I suspect we'll never go back to where it was historically, but I think that that gradually what will happen. I'm hoping that we'll get through the worst of Omicron over the next few months, and we will then move towards being in a situation where we will be able to enable more people to just book the face-to-face appointment that they want, because face-to-face is really important for trust, for real benefits. I mean, there's a big study in Norway looking at continuity of care and how important that is in terms of reducing emergency care, and I think we still have to keep that in mind. That's what people want to do, but we've gone through a technological revolution, and for a lot of people that adds convenience as well. So people don't necessarily want to have to leave work to go and see the doctor. If they could do it on a video call, on a phone call, we have to adapt to that as well. I think so. Team cohesion is going to be really crucial going forwards, and I think that working closer with our hospital colleagues and also at place-based level with a local authority, particularly around the prevention agenda, which I'm heavily involved in, because prevention is obviously better than cure. We need resources. We need better integration of our systems, wrapping around the patients. We need development of community services. Our community services are heavily stretched. District nurses services really stretched to the limit, and we've also got to work out how we're going to retain our general practitioners as well. We don't want people walking away. I know people who are retiring early because they do find the intensity too hard, and that's a disaster. But I think that on the whole, we will adapt. We will continue to deliver high quality care, and I think that we do retain a sense of hope. We do retain a sense of optimism, and I think the one thing I would say is that everybody that I've dealt with, certainly in my own practice, from the receptionists who've had to take an awful lot of challenge in terms of the way that they've had to deal with everything around them, to the people I work with, my partners, my staff, my management. They really care about the NHS, and they really care about patient care, and that's not going to go away ever. So I do retain that sense of optimism that is that we will respond to this, and we will adapt to it, and we will continue to provide high quality care as we've always wanted to.
Well, thank you very much for that. That was most interesting. Before I go around to see who else would like to ask questions, I'd just like to raise one or 2 points with you. Clearly, we never will go back to what we knew 3 years ago. That's very clear. There are things, first of all, I'll raise the receptionists because you have done. And clearly there are good practices and there are not such good practices, and people will judge that in the way that they are treated, not necessarily by the doctors, but by the receptionists. I think it's possible that patients don't understand, by lack of communication perhaps from the surgery, how things have changed and how receptionists can make decisions as to whether you see a doctor or not. And I think in general, their attitude when they have to tell somebody that there isn't an appointment, would you agree, is a challenging way to say to a patient, I'm sorry, there are no appointments. But it's not the fact there isn't an appointment, it's the fact that they are told in a rather rough, rude way. That is what is coming to me as to how people feel. And how do you see for the future? Obviously, people do like face-to-face appointments with their GP. That's what they've known. I think there needs to be some communication, possibly when all this is over, that things will change and will change for good. But there are people who just need to reorder a prescription or find out a result from a blood test. How can that be directed by a phone call rather than holding up the main phone line every morning? Because people always dash for the phone at 8 o'clock to ring through to the GP. But there will be people there wanting to know their results. Would it be an advantage, do you think, in the future for 2 lines, one for results or questions and one for seeing a doctor, so that it speeds that morning up? Because some people are waiting a quarter of an hour when they probably should be on the road going to work, but trying to get through to the doctor. I mean, these are things that I see that need some thought, because there are many, many things that people just want to ask a result, but they're having to go on the same line where they would book an appointment to speak to the doctor. Just your thoughts on that, Dr. Griffiths.
I think what you're talking about is the interface, isn't it? It's the interface between the user and the system.
Yes.
I'm sure that I'm sure more can be done to educate the population about how changes are made. The difficulty is that it's such a dynamic process. There are literally, we are adapting on a almost daily basis to what's going on. I think without wanting to stereotype, I think reception teams do have a very difficult task, because they're often the places where the emotion that is in that interaction, they're often the people that receive the brunt of it. You know, and I've had that times in the past where patients can be very, very dissatisfied with the reception. When I talk to them, they've changed completely. I understand that it's an emotional interface. People want to have their problem sorted as quickly as possible. General practices are similar, but they're all different as well, and they can operate at very different scales, from group practices down to individual single-handed practices as well. So I think with anything like that, it relies on the sophistication of how you actually measure those sort of interactions. You know, and that it relies on good design of questionnaires that people can feed back, and the ability for every system is iterative. It can be evolved. It can be changed, but it relies on those sort of moments of disquiet being translated into something that actually designs the system better at individual practice level.
And your thoughts on how there will be in the future more virtual calls, more calls to the patient rather than the patient coming in face to face, because some of these can be addressed through a telephone call.
Yeah.
So how can it be directed straight for that purpose rather than taking up time in the mornings when people are trying to book actual face-to-face doctor appointments? How can people get their results and ask questions, check blood tests, whatever, without holding up that initial line at 8 o'clock? Would there be an advantage of 2 telephone numbers?
Well, the majority. I mean, I know my own practice. We have a single number, but we have multiple lines that you can ring from it. So I think it. You know, that's a technological aspect. I know that we do an awful lot of. I provide a lot of results literally to somebody's phone. So if I read them, I send them a message to say.
So it can be done by text.
Yeah, results are all normal, or please book an appointment with me. I need to talk to you about this. So there are ways of filtering that. So it's more that information is pushed from the practices as opposed to pulled down by the patient.
Yeah, and
I think as well there will also increasingly things like the NHS app as well, which I think in my own practice about 45% people have this, and that's going to be a way for patients to be able to access information as well. There are systems already that people can access there will be increasing ability for people to access their records, what's recorded about them.
I think this is the important thing, and it all comes down basically to communication, doesn't it? Okay, thank you. Anybody wanting any questions? Vice Chairman.
Oh, sorry.
There we go. Thank you, Dr. Griffiths. That was absolutely fantastic. The amount of detail you went into and builds on what we heard from Dr. Stephen Short and Dr. John Doddy at our last committee session. Really, really appreciate that. I think it's very pertinent as well that you've come in your scrubs today, because it reminds this committee what this committee is actually about. It's about frontline. It's about real medical services to real people across Nottinghamshire. And I note that you said you're going on, I believe, to vaccinate in a care home this afternoon. I just really want to say thank you. I know the whole committee would, for the work you're doing. I know you also wear a number of hats, because this chamber is very familiar to you. I've been at one of the health and wellbeing boards where you're sat in the hot seat there, as in your role as vice chair. So really, really grateful for the work you're doing, and of course the wider NHS as well. So mindful of the fact that we do live in a country where, although the services are far from perfect, we have them. I was listening to a radio program the other day about vaccination rates across the world, and boy, we are somewhat ahead of the curve in that game. But that all comes at a cost, and to hear you talking of 50 patients in a day for an average GP, that's 7, 8, 9, 10 patients an hour, and bringing, it was very pertinent, three different patients, all with thoughts of suicide, I cannot imagine the emotional and the physical impact on you and your teams. And I think on behalf of the committee, we just absolutely stand 100% behind the work you're doing and the NHS. So thank you. Also probably great that you're wearing a scrub, seeing as 2 members of the committee this morning have bronchitis. So we might need you to actually undertake in some medical capacity. I just, as you came to sit down, I went to the toilet here. And there is a notice above the urinal. Forgive me, Chair, for bringing such details to the committee.
Of course.
But it reads, problems with the waterworks, no need to call a plumber. And it reminded me of a recent conversation I've had with one of my constituents who has had problems with their waterworks and as a result have tried to access PSA blood testing for prostate cancer. And the stories they've relayed have been quite complex in their ability to access those services. Eventually, they did get the PSA test they required, but they had to travel quite a distance away from their normal GP surgery to do that. And it just made me wonder what impact this whole COVID arena, all the stresses and strains you're under, have had on these regular routine tests that screen out really important things like prostate cancer. I'm thinking of other blood tests for cancer, for ovarian cancer and also bowel cancer, the stool test, all of these things. Is access to those services getting through, or is there a backlog of patients because of the COVID? Just your thoughts on that. And also, just on the back of that as well, the old, I think they used to be called well men and well women tests, but just the general, I think are they called health checks in this day and age? I don't know. Are they still being undertaken? And what age groups are receiving those? And is this still the same level of those health checks which pick up on these underlying conditions? Is that all still going on? Thank you.
Thank you for that, Councillor Barney. I think it's really important, actually. The PSA test, I don't know the exact details for the individual. It may have been appropriate for that individual, it may not, and that's difficult to say. But males can request the PSA test above the age of 50. They're able to do that, but there are limitations with that as a test. So it's not the most accurate test in the world, and therefore it has to be taken in a clinical context. In terms of screening programs are still ongoing. There's not the NHS screening programs for breast, aneurysms, cervical screening. That's always continued. In terms of long-term condition management, I think it would be fair to say that there was a window of time when people were not presenting to the same extent into primary care. There was a suspension of. We have a part of our contracts is quality and outcomes framework, which is around about the management of long-term conditions, and that's target driven, and that was suspended initially. It's not at the moment, but it was suspended for the first year of the COVID situation. So there was a difference in the way that long-term condition care was managed, but I think it would be fair to say that certainly in my own practice, we attempted to ensure that everybody who had those conditions was still getting, we were still checking things, we were still doing things like blood tests, but then we had a period of time when we didn't have blood bottles. So even the very fundamental basics became a huge challenge. And then there's been the catch-up period. So we've had to try and catch up the long-term condition management. But I think that's pretty much online now. I think that's back to how it was. Yeah, so that a dip, and that would be reflective in the presentation into primary care and even secondary care. You know, I remember that the first nights of COVID, casualty was empty. Bizarre. Now it's absolutely teeming with people. But human behaviour does adapt, and there was a period of time where people didn't really want to come into buildings because they thought, where would I more likely to get sick? Well, in a doctor's surgery where there's ill people, and people stayed away. So that was a challenge, and we still see people now who are reluctant to go out. You know, people have changed their behaviour. So I think there is a definite recovery in long-term condition management, and I think we've also seen as well we've seen changes in patient behaviour as well. I think that there has been an increase in demand for service for some individuals. So people, I'd say 50% of people have wanted to really change their lifestyles, and have wanted information on how to do so. So, and people have been more receptive. People have been more aware of their own mortality and morbidity. Hopefully, we'll get through this next wave, and then a lot of those sort of measures we'll be able to actually look, and we need a lot of the data to inform us. But long-term condition management may well change. So, for instance, with our asthmatics now, as opposed to bringing people in for an asthma check and being told, well, I'm absolutely fine, we're able to do questionnaires, so they go to the phone, give us their results. If all's well, that's fine. They're on the right treatment. We want to use our time, our restricted amount of time, to see people who are not well managed, who are not well cared for, who have got problems. We don't want to be necessarily seeing people who are well controlled and for whom there can be a lighter touch, if you like. It's about optimising resources, usage.
Thank you. Councillor Wilmot.
Thank you, Dr. Griffiths, for your very, very informative approach to what is a very difficult times. And can I say that it's been a pleasure to listen to you, because you're so informative and so easy to listen to, which has been a very much difficult situation. In the 6 months that I've been on this authority, some of the people that come in to talk to us, very, very difficult to follow. Very difficult. But you yourself, absolutely magnificent. Can I say, I've got no problems at all against doctors, nurses, receptionists. They all work extremely hard. But we have to say access to GPs remains a critical issue across Nottinghamshire, especially in my town of Hucknall. In previous meetings, the situation with the lack of face-to-face appointments has been laid bare without any doubt. Despite platitudes received by the Secretary of State for Health, a huge percentage of residents simply cannot get face-to-face appointments with their GP for love nor money. Many GPs have almost taken on the role of call centre operatives in their role as waiting times continue to rise. With the rising COVID-19 cases, this situation is getting worse, yet we are seeing little improvement as anxiety and stress among GPs and their staff is at the highest for a generation. Now, I've just heard part of Hucknall are suffering from some of the highest COVID figures in Nottinghamshire. The figures released by the government today shows that positive cases of COVID in Hucknall are way above the national average, which is a very serious situation. And there is no test kits in Hucknall. I've had 14 calls in the last 3 or 4 days saying there are no test kits available in Hucknall, which of course makes the situation, as the figures that I've just told you must be an absolute tip of the iceberg. So a real situation. So what impact has the rise in COVID-19 cases and the vaccination programme had on access to primary care across Nottinghamshire? That's my first question. Do you want me to do one question? I've got 7 or 8 questions. Would you like me to do them one at a time, or give you... Well, I'll carry on then. So the first one, what impact has the rise in COVID-19 cases and the vaccination programme had on access to primary care across Nottinghamshire? Now, I'd love to know your opinion of the system. What extra measures can be taken to improve patient access to general practitioners? Your opinion. Now, the serious, you've talked about this, cancer, problems with cancer, serious condition of patients with cancers. How will doctors ensure patients are seen as soon as possible and referred, of course? Because it must be a monstrous situation on that. Because without getting the person in and getting some sort of knowledge of whether they have got the situation, it must be a terrible situation for you. Now, the patient's difficulty in phoning and not getting through, that's been a major issue. Some surgeries are changing. They're making it so you can press buttons to get to different situations. I don't know whether you feel that's the right thing to do or whatever, but it does need improving. There's no doubt about that. Now, what training is given to receptionists? Because when I ring up a receptionist, how does she know how serious my position is? Whether I need a face-to-face, whether I need a telephone, or just to take a couple of aspirins and see how you are in the morning situation. I just wondered how much work you go towards the receptionist to see for them to make a good diagnosis. Because they shouldn't be making diagnoses really, but they have to, because you're so stressed and so many people ringing up all the time. Now then, poor performing surgeries. We know we've got a list now. We've been sent through to us performing how badly or how good the surgeries are. What actually happens when you see these surgeries performing poorly? Is there something done about it? Do they have visits to make sure that the doctors are doing the right things? And because everybody makes mistakes. I just wondered how that was. So that's my question. And thanks very much, as I say, for all the information you've given to us.
Yeah. Yes. Yeah.
The second one, what measures, in your opinion, can we take to improve patient access to general practitioners?
I think there will be a gradual increase across the system as the pressures from the pandemic are mitigated. I think we're going to have a difficult couple of months, but then I would like to think we will be able to see changes. I can't see there's going to be a huge amount of change across the system. We've got quite a mild winter at the moment. Hopefully it remains that way. But we're still in a...
You talked about the cancer patients and the serious issue. Yeah. And the condition. How will doctors ensure patients are seen and referred as soon as possible to hospitals?
I'm sorry to interrupt. Could participants just use their microphones, because then it gets broadcast? Thank you.
Oh, mine went off. Again, you talked about the serious issue on cancer and other serious issues. How will doctors ensure patients are seen and referred as soon as possible to the hospitals or whatever the work needs to be done?
A lot of that's going to depend on how the systems are set up. I mean, certainly, I don't. Receptionists are not there to be giving clinical advice, not at all. The way that we do it within our own practice is it's very much about the patient telling our reception team whether they feel they have a problem that needs to be seen today, or whether it's something that they feel it can wait. It's not necessary for the individual to provide information to the reception team. That's up to the individual. Now, some patients will disclose that. They will provide information to the reception team. Our receptionists are experienced individuals as well. You know, there are people who've been working at the interface for over a decade, so they can have a sense of what the situation is and the urgency. They can read emotions and those sort of things. But then it's up to the actual practice to then work out how the clinicians respond to the information that's provided. The way I would look at it is, if I think I need to actually physically see that person, I need to touch that person, I need to have that individual in front of me, then I will just arrange a face-to-face appointment with them. That's the way I personally would do it. And I would like to think that is the way that my colleagues operate.
The reason I put that question to you is that on the three occasions I've had to go to see or talk to the receptionist, it's been a different receptionist, and also receptionists have been under so much pressure. Some have left the surgeries and new people have come in. So that's the reason I ask you, what sort of information do you give to the receptionist to make sure you don't just say, oh, you're a receptionist and that's it, and you know, you get in touch with the when the patient gets in touch with you either tell them this, that, or the other.
Well, surgeries are managed. So general practices are businesses, and they will be managed, and the management will be responsible for training and the minimum standard of training of their reception team. So they're not just put on the front line and left to get on with it. There will be training, absolutely. Customer services.
My final question, of course, is as I say, we've got brilliant surgeries performing brilliantly, and we've got some not so brilliant. How does the system work to improve the poor performing surgeries?
So clinical commissioning groups in NHS England will have teams of individuals. If standards are perceived to be significantly low, to where there's potential risk to patients, then there will be people who will visit these teams, and there is remedial action that is expected. So we have our contracts. General practices are independent contractors, but they contract with the CCG, the clinical commissioning groups. And if they do have concerns, then they do have people. They usually have experienced, often recently retired general practitioners who are involved and who'll get involved. And there's also, I mean, there is also the CQC as well, the Quality Care Commissioning. The CQC, who will also have practices on the radar as well. I mean, there haven't been it's a light touch reassessment each year. At the moment, we've not had the visits to the practices for at least 5 years, but they will focus on practices that they do have concerns about as part of their regulation framework.
The final question on that answer is that who makes the decision if the surgery still performs inadequately to close the surgery? Or has that ever happened? I don't know.
Ultimately, the CQC has that decision making, and there have been practices across Nottingham that have been closed within the last 2 to 3 years.
Thank you. Anyone else, please, to ask a question? Yes, Councillor McGrath.
Thank you, Chair. First of all, Doctor, I'd like to say that Dr. Doddies and Dr. O'Neill's in Stainford are doing most of the things that you're saying, and the tremendous work that receptionists do is unbelievable, because I do know a lot of them personally, and they do get, well, I don't like to say abused, but they do get a lot of verbal trouble off. I think you understand what I mean, Doctor, don't you? But it's just a quick question. Is there any danger that, as you quite rightly said, we're going down that technological route, which helps you all, obviously. Is there any danger that we're forgetting about the people that are not so technologically minded? Is there a way that we've got a plan to help them? Because obviously with the old people, not old uns, right? As they go, a lot of people in the different communities who are afraid of technology, have we got a plan to help them moving forward? I know it's difficult with the pandemic, right, that you can plan to go out and see them, but hopefully, whenever we get out of this show, right, not show, I didn't mean it that way, this pandemic, will we have a plan clinically across Nottinghamshire how to deal with the people that's outside of this? Thank you.
I think one of the big challenges going forwards, and particularly around the Health and Wellbeing Board, is around addressing inequalities. And what we don't want to do is to put things in place that actually widen inequalities, so that we improve the access for some people, or improve the flexibility of that arrangement for some, and then make it harder for others. I don't think we'll go down that road. I think practices are sufficiently sensitive to know when the situation is such that individuals can't use technology, and adapt accordingly. And I think we'll end up with different models for different cohorts. So I think there will be the more traditional type model, if you like, for those individuals who cannot use technologies, and I think there'll be the more modern approach, if you like, for those who can and want to use those technologies. And I think that will gradually change as populations age. But there are an awful lot of individuals, 70s, 80s, who are very au fait with technology, and I don't think we can necessarily say it's about different age groups. We have to look at the individual, because there are individuals who are not engaged with technologies who are much younger. So it's very much about the person and trying to develop a sensitivity and a flexibility. So it's not one size fits all, but it's about increasing the menu that's open to the public.
Anyone else? No? Oh, Councillor Adams.
Thank you, Chair. Yeah, just a small thing, really. Thanks again for that. Just something that, again, that I raised previously, which was around using call queues and sharing resource across call-taking abilities as well, across different groups to, again, when we're hitting with, obviously one of the biggest challenges, as we know now, coming out of COVID, is more the loss of staff for the isolation purposes, as far as actual people attending work, which is going to cause additional problems moving forward with just keeping services open. That's how I see those challenges. And so sharing things like call queues and things like that, and call stats and answer statistics and things across the board would also be really useful. And I think specifically, like we've talked about the early morning call to try and get an appointment, the frustration I think felt of having to dial, substantial amount of times to get through. If potentially that resource could be shared, or that window opened wider, it may be that by doing that people are losing a bit of that frustration as well, and maybe as people have already mentioned in here, that, and I think you mentioned it yourself as well, the sometimes negative impact on the receptionist, and maybe some of the feeling towards that animosity that builds up would be reduced as a result of that also. And I wondered if that was The other two doctors that were in previously raised that they were looking into that, and that was something that was being advanced. And I wondered if that was the same for yourself also.
Primary care networks, GP federations are still fairly fledgling as organisations, and I think there certainly have been conversations that I've been party to that have talked about that as a possibility, and the wider use of a network in terms of managing demand. Whether that will be something that is as part of a strategy, it's certainly not at this moment in time, but it won't be a surprise that as our population ages and potentially grows as well locally, that we'll have to think about.
Yeah, I was going to just say, because I think specifically with pandemics highlighted quite a key point, because we've had areas that have specifically been hit, if you like, at different times. You've noticed that infection rates, maybe not so much in the more recent peaks, but previously and originally you were finding whole areas, for example, where I live, it was completely clear for months. There was no infection at all, whereas in other areas it was significantly heightened. And it occurred to me at the time that, you effectively could be accessing and utilising a resource in the area that I was living when the staffing was short in the area because of isolation where the figures were peaking. And you're able to then, maximise that resource across the board and help each other out, which I know is, something that and as you were explaining before about how things are changing would really help that. And I think specifically in emergency situations like pandemics, rather than maybe, every day as well, but if you've got a sickness absence or something like that. I think it would be, personally, I think it would be a great move. Thank you.
I think one of the things that's highly useful now is the fact there used to be several different IT providers, main providers for general practice. It's now whittled down to two main ones, and that means that actually the ability to share records. So, for instance, out of hours work now at weekends, so there are general practice services at weekends and in evenings where people can actually access the full records. Once you start breaking those down, you then are into the argument about, well, how much is important for continuity of care, as I talked about the work that's come out of Norway, the importance of continuity versus care at the point of delivery. So does it matter, if my car breaks down, does it matter if it's the RAC or the AA that comes? Or does it matter as long as I get my car going? It's that sort of model. Or is it important for me to have a single provider that actually does everything and knows me? And I think with anything, these things are often hybrids. But I think there is going to be the potential going forwards. That may well change. General practice has always been based on a partnership model. So individual businesses with partners. One of the things that we're now seeing is that younger general practitioners are less interested in the partnership model. And it may well be that if people are not necessarily interested in the partnership model, that actually new models emerge, and as a result of that, networks may well be different in the way that they interact with each other. So that it may not be a here and now, but it may be something that's coming.
Councillor Welsh, did you want a word? I'm mindful that Dr. Griffiths may have to go, so I think we probably make...
I did put my hand up quite a while ago, though.
Pardon?
I did put my hand up quite a while ago. Yeah, very, very quickly, sorry. You mentioned about the fact that there was 2,000 patients kind of on a caseload with regards to a GP, and there was up to seeing 50 patients. I've actually got a really good friend of mine who's a GP that frequently sees 70 patients a day. I'm just wondering how sustainable that is in the long run, because to me that seems like a huge amount of people that are on each GPs, but also a lot of people that you're having to see during the day. And I just wondered how long-term, how sustainable that is for GPs. Because you did talk about people that are early retirement, and also I actually have like I said, friends that are GP that are actually considering leaving the profession because having children and being a GP at the same time under the current size putting enormous pressures on, and that for me is quite worrying about the long term, future of our GP services. So that's the first thing. The other thing with regards to when we talk about online appointments, I've had some really interesting conversations within my wider family and friends, and there's sometimes this notion that if you get an online appointment or you get a phone appointment, you're getting a lesser service. So again, I think that's a bit about communication, isn't it, as well? Because I'm happy enough to have a phone call appointment with a GP or an online one with my GP when my little boy had a rash, but it was lockdown and I didn't really know what to do about it and whether it was serious or not. And actually, I didn't need to go into the surgery and I was fine with that. But there is sometimes that preconception from people that if they're not getting a face-to-face, then I'm not getting a good enough appointment. And so I think this communication isn't there with regards to that it's not any less of a appointment, and if after the telephone conversation it's felt that you need to come in, you will be invited in to the surgery. And last but not least, because I did get a lot of grief when something was said about receptionists previously, because I've got family members that are doctors, receptionists. There is, as I understand, quite a lot of work with regards to how receptionists have been treated throughout the pandemic. And actually there has been a rise of abuse and kind of aggression towards them because they are having to manage quite an extreme situation. So whilst I'll accept what some of other people are saying, that sometimes it's very, very difficult for people to get a doctor's appointment, I also have quite an ongoing concern about how doctors, receptionists are actually support, because they're often forgot that they have been frontline workers to all of this, and it has been a massive changes for GP surgeries, as you know, came very much overnight and they had to adapt very quickly. So with regards to the welfare of doctors, receptionists, that whatever way we look at are absolutely critical, is there support being put in place for them that are having to face kind of the abuse and the aggression that they often get when they can't give that person exactly what they need when they wanted it? And just to say thank you as well, because I think GPs have had an extraordinary role during the pandemic, and more so from a mother's perspective and someone that works with lockdown mums. You've actually filled a huge void in paediatric care when health visitors weren't available and you'd had a baby during lockdown. For the lockdown mums that I'm involved with that are across Nottinghamshire, the GPs have been that point of service, and never once was an appointment, wherever it was in Nottinghamshire, never once was an appointment refused when it was a baby. And I think that is something that GP services need to be very, very proud of, because it was essential and very important. So I'd personally like to say thank you.
Thank you for that. In terms of the actual GP retaining our general practitioners, I think we have to acknowledge that there's one of the things that happens in general practice all the time is about the management of risk. We manage clinical risk all the time, and I think what's happened going through the pandemic is that the way people manage risk has had to change. One of the things that people really fear is litigation, the complaint letter, getting something wrong and going, if I'd have managed it in a slightly different way. And there's no doubt that, I'm sure that things have happened. I know that I can, do we get everything 100% right? No, we don't. We're human beings at the end of the day. I think it's going to be a case of one of the other things that we're doing at the moment is that because there are delays in the hospital sector in terms of getting access to outpatients, we often have to manage conditions that we think need to be seen in the hospital sector for longer and deal with when am I going to be able to access information, when am I going to access my appointment, and changes in those clinical conditions as well. So we're having to take more clinical responsibility, if you like. And the GPs are generalists, but they're not specialists, and we just need to ensure that there is adequate support and response within the system when we do feel there's escalation of problems. So how do we retain them? I think one of the things that you talk about, I mean, you say about the 50 patients, 70 patients, that's not every day. And that I was talking about, I was illustrating, that was when my on-call was. I mean, if I do a typical list, it'll be around 15 people in the morning, 15 people in the afternoon, maybe up to 18. That sort of numbers. But when I'm talking about the on-call, that was when I was saying about the 50. And I suspect that's the 70 as well, is when it's the on-call demand. Look, I think we just have to keep adapting. I think, maintaining communication, maintaining morale, trying to acknowledge when people are fatigued within our practices, looking at flexibility of roles, looking at flexibility of how people can continue to work, but maybe we have to accept that people's energy levels are not the same as they approach 60 as they are when they're in their 20s and 30s. They're just not the same. So it's about flexibility of working model as well, I think, as well. So that was around the first point. In terms of, there are support services for general practice and their staff in the community. There are national services that are available that people can access, and obviously occupational health if there are bigger issues. So I missed your second. Which was your second one? Your second point. One was about GP recruitment.
Communication with regards to just because you get an online appointment doesn't mean it's any less of an appointment than if you come and see.
I think there maybe is a piece of work that needs to be done to explain to patients how the new models will evolve and what it does mean. As you say, it's not about it's still communication. I mean, I personally, when we weren't seeing that many people face to face, didn't enjoy it that much. I did feel like somebody said about call centre. It did feel like I was working in a call centre. I didn't train for that. I trained to. I'm a people person. I like to see people. There are subtleties. John Doddy talked about it last time. There's the subtleties that you might pick up. And patients have an agenda when they come to you. There's a saying that says, "What's the matter with me?" and what matters to you. And what's the matter with me is what the patient comes to me with. But then there's also the bit that I can pick up about saying, well, actually, what matters to you? Are you still smoking? You're still maybe drinking a little bit too much? Are you carrying a bit too much weight? Are you not exercising? Are you looking after your psychological well-being? That maybe we will miss out on if we don't have those face-to-face contacts. Somebody mentioned about the health checks. So I didn't answer that question. But the health checks at the moment, they're suspended activity. But what we hope is that they will come back. They're not the same as a screening activity where there's actually a strong evidence base behind them. But what we do know is that we pick up things and we're actually able to reduce a lot of the risk of particularly heart disease and stroke by altering behaviours and earlier treatment. So really, really pushing hard on prevention going forwards is absolutely the name of the game, and getting patients to be able to manage their conditions better, so that actually when they do come in contact with us, that's when they really do need us to help all of them and the whole person, not just what the initial thing that they want to deal with.
Thank you very much, Dr. Griffiths. I think this morning's briefing from you has been extremely useful, and certainly GPs are at the front of trying to deal with COVID and all our concerned patients. So our thanks to you, as has been expressed, but our thanks to all the GPs who are working tirelessly to try and get this terrible virus under control. And you know, all we can say is that we will continue to look at this access to primary care, and we will have other GPs in to have a discussion as to how they're coping with it. Then we will pull together our findings, but we're very mindful that we're dealing with a very different situation looking at access to primary care, because we're looking at it in the middle of COVID, not in the normal circumstances. So this has obviously got to be a consideration. But thank you very much. I do appreciate you coming to speak to us. It's always nice, as you've said, to see people face to face. You feel it's much better. But we shall let you go. I'm sure you've got your old people in the care home or wherever they are desperately wanting their injections today. Thank you very much indeed.
Thanks very much, and thank you for your public service. It's much appreciated.
Thank you. Thanks very much. So, members, that really brings us to the end of the meeting. Next meeting is on February the 22nd, I believe, and we should be discussing tomorrow's NUH. And I say should because as yet they haven't got their information together to come and discuss it with us. It's Lucy Datch, who's the Commissioner for the CCG. She hadn't, when Martin spoke to her, got her information together. So it will depend on whether they're actually ready to bring the information. And also, we will start to look at mental health. And clearly, through this COVID epidemic, many people have been affected. So I think we need to adapt that. And probably at the beginning of the meeting, or at the end of the meeting, when we've had the briefing on mental health, have a look how we're going to look at it. Is it the old people who've been left in their homes locked up that are suffering? Is it the young children who haven't been able to go to school? Who has been affected, and what are we as a local authority and what are other groups doing to try and help these people out of this terrible situation? And that's apart from the general people who suffer mental health without any COVID, long before COVID came and arrived on our doorstep. Because we were going to discuss this before COVID was as bad as it is. But I think it's brought a different angle to it now because of the fact that so many people are being disenfranchised from their normal life. And we've got schools opening today, and what is going to happen, we have no idea. So I think we need to look at it. I think it's going to be slow to look at, but I think we just generally need to form some ideas. So we will do that. What happens with tomorrow's NUH is anybody's guess at the moment, but we've got a month and we'll see where we go from there. So thank you, members. Happy New Year to you all. Healthy New Year, and thank you for coming. Safe trip home. Can we have the